Start the recording. So I will just try to just repeat for the people. The topic for today's discussion is ambulatory or out of OR anesthesia. So there are certain challenges which we will be facing if we are giving anesthesia in out of OR. There is limited manpower. There is limited access in the way that some of the procedures like an MRI and the patient access is limited. Specialized equipment is needed, and there is limited manpower. There is unfamiliar environment. Okay, so we are providing this out of OR anesthesia in in MRI, CT scan, yeah, and then endoscopy suite, interventional radiology, which is called as also angio suite, some procedure done in ICU bedside under anesthesia care, radiation therapy, laser therapy. One will be is in the OR, but one of them is also in the dermatological suite. Okay, so these are the thing. Then one of another component which is also there in is dental anesthesia. Okay, sometimes dental procedures are also being done out of OR. Yes, ECT is also electroconvulsive therapy is also being done in out of our own environment. Sometimes bedside there are people who are doing T, transesophageal echo. Okay, so sometimes transesophageal echo is also being done bedside. There are some other procedures which are being done with the concept which is part and parcel of anesthesia outside OR is MAC. So, can you tell me what is MAC? Can someone tell what is MAC?
Monitored anesthesia.
Your voice is gone. Can you repeat, please?
Monitored anesthesia care.
Okay, so how will you tell that what is monitored anesthesia care?
So we are just monitoring the patient and we are just giving mild sedation in that
No.
monitored anesthesia care.
Is it mandatory to give anesthesia?
It is not mandatory.
Okay. So the
If
example of
required only we will give.
this example of not giving anesthesia at all and monitoring the patient is biggest
Standby
example,
anesthesia.
cataract. Okay. Biggest
Okay.
example is cataract because a lot of cases are being done of cataract or also vitrectomy or some procedures which are being done under monitored anesthesia care. So monitored anesthesia care is the provision of a trained anesthetist providing monitoring of basic standards, okay, and with or without giving anesthesia. It may be like you are giving some a little bit of sedation. So there another concept will come. What is difference between conscious sedation, deep sedation, and GA? How can you differentiate? Can anyone tell? What is conscious sedation? What is deep sedation? And what is difference between deep sedation versus GA? Please, Faiza, batao. Just tell me. What is difference between conscious sedation, deep sedation, and GA?
Well, I think conscious sedation is a sedation level in which the patient can respond.
To what? Respond to slap, respond to surgical stimulus, respond to what?
Respond to our commands.
Verbal command, verbal command, or minimum tap. Like you can just, they are calling you, doctor, doctor, open the eyes, or you just tapping the patient. So this is Ramsey 0, 1. Okay. Because usually we decide we categorize with Ramsey scale. Okay. So, and what is difference between deep sedation and GA?
In GA we are securing the airway and in deep sedation we are not putting the endotracheal tube as
So
such.
it's the other way around. In deep sedation, patient's airway may be patient is not responding to minimum or verbal stimulus, but patient is maintaining the airway. Okay. So GA will be if you need to maintain the airway. So there is this a little bit difference between deep sedation and GA. Okay. So if the patient is not able to maintain, actually there is very narrow margin of error between. So a number of time when we are giving deep sedation, we lose the airway. So sometimes we are uh, putting our hands to elevate the airway, to clear the airway. We can put nasopharyngeal airway or oropharyngeal airway. Okay. And there is a special nasal cannula in which there is a provision of monitoring of end-tidal CO2. Okay. So if we want to give deep sedation, we need to monitor the end-tidal CO2. Okay. We can monitor it through just putting by some way placing the end-tidal this connection inside the face mask, or we can use that special category. Okay. So this is what are different options we can use for this sort of sedation. It is called as procedural sedation. Okay, procedural sedation. So, what options we will have for this thing? What medications we can use? What medications we
We
can
can
use?
use benzodiazepine,
Benzodiazepine,
benzodiazepines, dexmedetomidine.
dexmedetomidine. What else?
So low doses of propofol can also be used.
Propofol. What else?
Short-acting opioids,
What about ketamine? Opioids.
ketamine.
Okay. So now one by one, usually we will be making a combination. Okay. So that is called as cocktail. We can make a combination. So what will be the problems associated with benzodiazepine or say opioids or their combination?
So respiratory depression with the
Respiratory
profound
depression.
doses, respiratory depression.
And especially not in even in profound, even smallest of the dose can do it, especially if you are giving a combination, because if you are using uh, benzodiazepine and opioids together, they will have a synergistic effect. They will have a synergistic effect. The concept of synergistic effect will be 1 plus 1 will be more than 2. It will be 3 or 4. Okay. So they will be in. So if you are using, for example, dexmedetomidine or ketamine, the advantage is that respiratory depression will be that there will be less chances of decreased chances of respiratory depression. But still it can, because it will be related to the loss of consciousness. Loss of consciousness, the pharyngeal muscles, not only, remember one thing, there is two different things. One is respiratory depression and one is upper airway obstruction. These are two different things. Okay. Respiratory depression means, can anyone explain what is respiratory depression? We say this word again and again. Can we differentiate between respiratory depression? What is respiratory depression? Come on.
Is it decreased ventilatory response to hypoxia?
Yes, hypoxia or hypercarbia. Okay. If it is not responding to the normal stimulus, then you can say that it is called a respiratory depression. Upper airway obstruction is something else. The soft tissues, they block the airway, and now patient is having paradoxical breathing. That will be just relief just if you will really do the jaw thrust or chin lift maneuver. Jaw thrust, chin lift maneuver, the airway will be cleared, but respiratory depression will not be clear by these things. Okay. So this is a little bit of difference. This is a conceptual discussion about these things. Okay. So if you are using ketamine, what can be the problem with ketamine, especially if you have not secured the airway?
Salivation.
Secretions. Okay. So secretions can trigger laryngospasm. So this is, you should be thinking about it. So though it is not causing respiratory depression, but it still can create problem. Propofol, airway reflexes will be blunt and there will be chances of apnea. Okay, airway reflexes and apnea with propofol. Okay, so whenever you are giving procedural sedation, because now we will move forward, even we can do ERCP, even we can do ERCP or this gastroscopy, endoscopy, like in the form of either upper or GI endoscopy, upper or lower, in the form of this colonoscopy or gastroscopy, duodenoscopy. Okay, and ERCP is a procedure. So now we will move forward. Just few words about these procedures. What are the normal challenges one by one? What will be the problems in upper GI endoscopy? What will be the patient groups which will be going for endoscopy, upper GI endoscopy?
Septic ulcer disease, sir, or GI bleed.
GI bleed. So this is related to this is will be a tip of iceberg. GI bleed will be because of what? Maybe NSAIDs. NSAIDs may be because of some rheumatic disease, rheumatoid arthritis, or ankylosing spondylitis. Okay, or anything related to it, or any reason in which patient is taking steroids. Okay, so GI bleed will be a tip of iceberg. Then GI bleed will be because of portal hypertension, the varicose veins. Sorry, varicose. Just what you say? I'm sorry, using the wrong word. This varices, varices. Okay, esophageal varices. So this will open the door for end stage liver disease. Okay, or you can say liver failure. So though you are only looking at GI bleeding or GI endoscopy, so you should have everything in your mind, because if you just look at the procedure endoscopy, maybe endoscopy is just because of GERD, only simple. Okay, patient only taking H. pylori problem. Patient can have problem only because of this thing. So this is the simplest of the thing, but it may be a very serious problem. Okay, patient may be taking NSAIDs or another thing, poisoning. This may be done for poisoning as well. Okay, and a number of reason for endoscopy is also related to liver. Okay, so liver may be liver, or you can say liver and hepatobiliary, I would say. So a number of cases of pancreatic problems. Okay, liver, pancreas, or biliary tree. So not only they will be doing ERCP, endoscopic retrograde cholangiopancreography. There is another similar procedure, not like that. That is MRCP. Okay, so that is magnetic, that is through scope. So they can combine it as well in some places. Okay, so MRCP, ERCP, because you should be knowing about these things. Okay, so with reference to ERCP, can ERCP be done in procedural sedation? Yes or no?
Yes, sir.
Okay, so if you are doing it as procedural sedation, what can be the problems you can face?
Sir, upper airway problems.
Upper, like airway obstruction can occur. Airway
Yes, sir.
obstruction. And whenever airway is not secured, there is aspiration risk. Okay, then
Yes.
the sympathetic response can occur because patient is breathing, so these problems can occur. So if for example sudden bleeding occur, this can cause problem. Not only the gastric aspirate, the bleeding can also occur. So you have to be very careful. Plus it depends on the surgeon competency, because ERCP may be finished in in 10 minutes up to even 2 hours. I have done both of them. Plus another thing, sometimes surgeons, they are doing it in semi-prone or like you can say lateral position, but sometimes they are asking for full prone position. Okay, so in prone position, it will be difficult to maintain the airway once if you have a problem. So how you can troubleshoot, how you can cover these things? If you are having good gargles of lidocaine, topicalization with lidocaine, so this will help you. Okay, so this will reduce the dose of anesthetic agents. So if you reduce, because actually the painful step is only passing through the epiglottis and this area. Once the patient is once the scope is inside the stomach or inside the intestine, or they are doing the procedure, actually it's not painful. Okay, it's only sort of stretch, but it is not a very painful procedure. So they can, once they pass through this area, the rest of the things will be easy. Okay, so this is then some other problems which you can face during the procedure. They are asking, because if you are using opioids, what problem you can face in ERCP? Can anyone tell? What is relationship with ERCP and opioids?
Sphincter of Oddi constriction.
Very good. Okay, so sphincter of Oddi. So actually, I have, like, I don't have research paper, but in my experience, if I don't give opioids, I just replace it with ketamine and Presidex and other medications. So the chances of this problem are less. So because they are, sometimes they ask to give glucagon, sometimes they ask to give no, like this antispasmodic. Okay. So I have seen that in the patients in which I don't use opioids in particular in this procedure, it helps a lot. Okay. And I have done a lot of time without intubation. But if you have any doubt, because these patients sometimes will be very sick. These patient will be coming with pancreatic CA pancreas. Okay, so the variety of the patient will be totally different in different This patient's ERCP patient, they also will be coming with the biliary obstructed biliary tree. Okay, so these patients will have joined us. So again, this will be a problem. So, and then there is biliary atresia or obstruction following any previous biliary or hepatobiliary surgery, or especially the master surgery, the liver transplant. Okay, so this is a tip of iceberg. You are in OR, out of OR, you are in challenging environment. There is limited manpower, there is limited staff. Okay, you may be the only anesthetist over there with one anesthesia technician. Maybe you don't have all the anesthesia gadgets available in the endoscopy suite, and you are dealing with these terrible patients. Okay, so be ready whenever you are working in endo. Even they can ask this question in the in the exam, ERCP, and they can ask you, and then you have to tell the patient the variety of the patient. So thorough preoperative assessment is very important, because they are only coming for change of this stent. Sometimes they are only changing of stent. So this may be a simple procedure. Sometimes they can create a lot of problems. Okay, that like CA pancreatic patient, they will have all the problems, all the concerns related to carcinoma. So you have to be very careful. So endoscopic suit with reference to ERCP and GI. Another thing, if you are dealing with this one, just a second, please. Okay, so especially if you are dealing with colonoscopy, what thing you should be very careful for, especially in colonoscopy? Bradycardia.
Vasovagal. Hmm.
Yes. Okay. So similarly, what other procedure you have to be very careful? Any procedure with cervix, any procedure with the any procedure in with vagal stretch. Vagal stretch can occur like eye, ENT. Okay. So you have to be very careful in any like where they are stretching the mesentery, laparoscopic surgery. So you have to be very careful anywhere where there is chances of sudden bradycardia. So this is some words about. So ambulatory anesthesia, they can ask you in different way. They can ask you a specific procedure as well as like that. So colonoscopy or so there will be some additional diseases which can be there. One of them is inflammatory bowel disease. Okay. So maybe the patients are coming for Crohn's disease or this ulcerative colitis, okay, and also some CA. So whenever you are having a patient for colonoscopy, there may be only nothing, only for any differential diagnosis, patient has passed hard stool, there was some bleeding, and now they want to do colonoscopy. So it may be a nothing patient, and maybe it may be a patient taking steroids, taking immunosuppressants, okay, or patient with CA. So all the concerns related to CA, the chemotherapy, the radiotherapy, the immune suppression, the bone marrow suppression, the and like opioid dependence with reference to pain and this metastasis. So whenever the word CA comes, they will not ask you, but you have to tell. Okay, so and even if you are preparing a case in a practical conduct of anesthesia as well, you should be very clear about what can be the challenges. So up till now we have discussed the basic concept of out of OR anesthesia. We have discussed about some points about ERCP. We have discussed some points about endoscopic procedures. Okay, and aspiration, uh, the complication which can occur. Okay, so few words about MRI. Okay. So, what are the challenges in MRI? In addition to some of the things will be the common one. Here, what will be the challenges? It's a very cold environment. So patient can have hypothermia. It's a very noisy environment. I'm telling very simple things first because the difficult things we can discuss. So it's a very cold environment. It's a very noisy environment. You are away from the patient. Okay. All the equipment are dangerous. Sorry, equipment is like special MRI safe, or you can say MRI compatible equipment is needed. Okay, so you have special pulse oximeter, you have special BP cuff, you have special ECG leads. Okay, and there should be no metal, no metal. Even there is, do you know, metal in the endotracheal tube? Where metal in the endotracheal tube cuff, there is a metal, there is a spring. So you have to cover for it as well. And then the normal pulse oximeter, if you put it inside, there will be burn. Okay. So any implant may be orthopedic implant. Okay. Implant may be ophthalmic implant. Okay. Implant may be pacemaker. Okay. So any implant, like maybe there are some newer machines which have some compatibility with this implants, but normal machines they don't allow. Okay. So you have to be very careful about it. Uh, Another important point with reference to noise, you should be knowing, I don't remember the exact decibels. So please, for the exam candidates, just you should be knowing how much is the, I think 70 decibel, it's more than 70 decibel over in MRI. So they cover with the proper headphones. And in some people who are having they are not doing under anesthesia, they are having claustrophobia. So sometimes they are giving up them a choice. They cover the eyes and they give the headphones, and they let them have some songs or some religious rhymes which can keep them relaxed. So this is one of the way to handle these patients. Okay, because whatever patient is coming, yes. Another important thing is what usual type of patients which are coming for MRI. This is also very important thing. So there will be special pediatric patients with congenital anomalies. A number of times they will be coming, congenital anomalies. So whenever there is one congenital anomaly, you have to rule out other congenital anomalies. So these patients will have yes, neurosurgical are simple actually. Neurosurgical patients will be like whatever information you will be there. If there is a bleed or there is anything, this is simple. But here there is more challenges because pediatric age group has all the challenges of an altered anatomical, physiological, and pharmacological challenges, difficult IV line, consent issue, non-cooperative. You have to sometimes take IV line after induction. So inhalational induction, there is lighting. It's not a very lighted area. Sometimes there is limited light. There may be problems with the IV cannulation. Okay, so there are a lot of things you will be facing when you are dealing with such patients. So as I told you, that congenital anomalies patient, they will be coming. Yes, another important thing will be with reference to neurosurgical. The important thing is actually fits, because if you have an head injury patient, that is, you know everything, so you can anticipate accordingly. But some things will be gray area. Patient may have history of fits. Okay, intubated patients, yes, intubated patients can come directly from ICU. So the another component will be there because they will be coming for the diagnosis of epilepsy. Okay, so these patients can have, so you a number of times you have to make sure that even before diagnosis, they are receiving some medications which you can give in anticipation of possible, because in anesthesia a number of factors change. So there may be precipitation of epilepsy, so you have to be very careful in these patients. Okay. um, so the actually remember one thing, sometimes some points are not written, highlighted in the books. I'm trying to give you that concept because everything is written in book, but still we need to discuss the things. So the discussion is very important, and that's why I'm trying to give you a concept of what you will be facing, what challenges you will be facing when you are there. So because of limited access, your in addition to all the complicated patients, you will have challenges with reference to the logistics. Another thing, a number of times these procedures are as day surgery, majority of times. Some of the patient need admission, so all the concern with reference to day surgery, because you know you cannot give an anesthesia in which patient is sleeping for a long time. So you need to give an anesthesia in which the patient is getting up and is ready to discharge at a relatively earlier period. So this is also another challenge because of the financial constraint. Majority of time these procedures, because hospital is already overloaded with the inpatients, so they don't afford that the patient is occupying the bed only for MRI. Okay, so these things are also very important. So in addition to the, yes, fun some words, can someone tell what is the working principle of MRI? Especially patient people going for EDA. This is a question they can ask you. Or any exam candidate. You know, exam candidates are mute, silent. Iqra, Salim, Faiza. It's not a teaching session, it's a discussion session, and I would be very happy if you speak out. What is working principle of MRI? There are two magnetic
Sir,
fields. Yes.
magnetic fields
Okay.
make the protons and electrons around it, and they
Sorry,
detect
again, please. Again,
the
please.
magnet. Due to magnetic field, electrons and protons move, and because of that, they detect that the
Proton.
slices.
No, 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 no.
Yeah.
It's not like that. Actually, there are two powerful magnetic fields. One is constant, and one is constantly switching on and switching off. Okay. So it is just like parade of army. Stand up, sit down, stand up, sit down. Okay, so not all people are so active. So some will be going slowly, some will be going fast. So this will be the difference of the tissues. The pathological tissues, the protons response will be different than the normal tissue. The bony response will be different than the soft tissue. So that will be that's the basic concept. Okay. So whenever there is a powerful magnetic field, the protons go high energy level when it's switching on, and coming into lower energy level when it is switching off. This constant switching on, switching off, and the dancing movement of protons in different tissues. So that is recorded by the MRI recorder. Okay, and that is represented in the form of the pieces or scales which we are doing. So this is the basic. If you speak out like this, nobody will fail you. Yes, the cramming stuff will be which field is which gauze is the safe field, and this I don't remember. For that I need to review the text. Okay, so you can easily know, but the basic principle is like that. If you are having a wallet in your pocket and you forgot to remove it, be ready for sweeping of clearing of all your credit cards, even your smart car keys. Okay, everything will be lost, because that magnetic field will lose all the data which is there in there, that credit cards, or okay. And of course, if it is metal, it will be pulled out. Okay, so these are the things which you should be knowing with reference to MRI. Okay, so any other any point which I've missed with reference to MRI? Because MRI is a big topic, but I just try to give you a bird eye view. Just a second, please. Okay, so anyone wants to just add on to what we have discussed up till now? The exam candidates are silent, and I'm very upset. Faiza, why you are mute? Ikra, why you are mute? At least two people I know. I don't know about others.
Sir, can you please tell us few points regarding laser surgery?
Laser, I'm coming. You are only stuck on laser. MRI is also in the course. You did not speak out anything about MRI. Have you understand this topic? Yes, Faiza.
Yes, sir. We can also discuss concerns related to the if a pediatric child came for the MRI. So, what kind of sedation can take?
Actually, your sound voice is very I couldn't understand your question. You said that some choice of the medications being used for MRI. Did you say like that? The same medications which we discussed, usually because this is not a painful procedure. Am I right? So you just need to blunt the reflexes. Usually, majority of cases, unless there is a problem, usually we do this in LMA. Okay, because you just have to blunt the stress response of LMA, and later on you don't need and because there will be no pain, so you don't need anything else. Usually, only the dexamethasone and ondansetron for the this prophylaxis of vomiting, and this one propofol induction with lidocaine. No need for muscle relaxant majority cases, and you can just maintain it with sevoflurane. If you are giving sedation, of course, it will be a difficult job. It will be a difficult job, especially in pediatric patient with limited access. If the patient airway suddenly collapse, how will you maintain? So usually it's never advisable to proceed without securing the airway. Okay. So these are so okay. So what is laser? Actually, laser is a topic which uh, I always run away from. Okay. So basically, I will just tell you what exactly they can ask you about laser. So first of all, who will tell what is this abbreviation meant for? What is this abbreviation for? light amplification by stimulated emission of radiation. Okay, so actually it's a emission of a monochromatic. What do you mean by monochromatic?
Sir, with the same wavelength.
Wavelength. Okay, so wavelength is mono. Coherent. The word telling you they are in an order. Okay, they are in an order and they are in the same phase, you can say, solid or liquid or whatever. Okay, and then another word which is written is collimated. So they are arranged in lines parallel. Okay, with little divergence from the point of origin, like they are going in straight lines. So that is collimated. So this is the thing which is important. So you should be knowing that they are in one phase, they are in one wavelength, they are coherent. Okay. So if you just go to the components, so actually there is a media. So either it is there are different media that, like there is a solid, liquid, and gas as well. So usually carbon dioxide laser is example of gas laser. There are some other sorry, YAG laser, ND YAG. I'm not very good at it, but there are different phases. One is solid, liquid, and gas. So example of gas is helium or CO2. Okay, and there are some dyes which are there. So then there is an energy level, which is maybe a high voltage discharge, a mechanical reaction, diode, flash. Uh, this is the basic details. Okay, believe me, they will ask you the question in this first thing which I have told you. They will usually ask you this question, that what is laser, what is the basic concept of laser. Okay, and then they will be asking you what are different types of laser with their wavelengths. So you should be knowing that there is one the laser which have high wavelength has less penetration, and the laser which have less wavelength has high penetration. This is the basic rule. Am I right? Am I telling you the correct way? Because the highest wavelength is of carbon dioxide. Okay, and the minimum is of argon. Okay, and usually ND YAG is in between. Okay, so this is the basic, because it details just like in MRI, there are so many details which they can ask you, but usually this is the more than enough information. If you are able to answer these questions, maybe you will pass that part. Now comes the anesthesia concerns. This is one will be with reference to airway. If it is airway laser, even if it is not airway laser, even if they are using it for urology procedures, there will be that if the laser beam is misdirected, it can damage it's an occupational hazard. So whenever they are using laser outside the operation room, it's clearly mentioned with the danger sign that laser inside. So people are wearing laser glasses, gloves. Okay, so they should be protected for the against the occupational hazards. Okay, so this is because it can cause skin irritation, eyes. Okay, so this is one point. So another, now the last and important thing about is airway fire. By the way, has any one of you seen airway fire? Anyone of you
No,
face
sir.
airway fire? Sorry,
No, sir, I haven't seen.
I am lucky to have 2 times with the same surgeon in the duration of 6 months. And then I was so afraid of that person, because before that I have done a number of times laser surgery, but I don't know what he used to do. There was some problem in his technique or something. So the safest technique for that person was to used to give him oxygenate the patient and then give him apnea, because even with minimum oxygen, there was two times, I don't know the reason, but there were two times I heard saw the smoke coming out and the sound of psh. So so what you have to do immediately at that time? What should be the response? Because they will ask you this question.
Disconnect.
Disconnect, then
Then remove the ATT.
actually there are two different school of thoughts. Some people say that you have to irrigate and then remove. Okay. In some books it's written that you will remove the tube. So the point is that if there is fire and you pull out, it can damage. I don't know. I am not sure about it because lucky I don't have to appear in the exam. But this is a confusion you need to verify. In the sources which I have seen, actually they say that you have to remove. Okay. But the thing is, the only point practically which haunts, that if you remove the tube with fire, it can cause more problems. Okay. So this is the only thing, that either you have to irrigate before or you have to irrigate after. This is the thing. And the next step will be you will do the rigid bronchoscopy or followed by flexible bronchoscopy to see any damages. Okay. So this will be and then you will again intubate.
Intubate.
Will there be any role of steroids? Yes. Will there be role of steroids? Anti-inflammatory. This is again a question of debate, because in my opinion, steroids should be given because it will reduce the edema if there is a hair occur, but I'm not sure about it. I have not. In my opinion, I think steroids need to be given. Okay, for as an anti-inflammatory. Antibiotic, I don't think so. Antibiotics are needed unless there is any infection, because usually they don't have any infective element in this one. With reference to laser surgery, you remember one thing: there are certain vocal cords procedures, okay, and a very important is the subglottic stenosis. Okay, a number of time they are doing the laser procedure for subglottic stenosis, and so these patients are usually tracheostomized. Okay, or if even if they are not tracheostomized, you have to send the patient as post-op to ICU, because they can have edema post-operatively. So the laser surgery, whenever you are doing, there are specific laser tubes, metallic tube, or there are tubes with the double this cuff, okay, in which they also put even saline, and also what they put, methylene blue. What is the reason for methylene blue? Yes,
The cuff rupture will be visible.
sorry. So actually they will come to know if it will be, if the cuff is leaked or there is a laser head damage, so you will be able to come to know. Okay. So there are different types of endotracheal tubes. There are some tubes with foil wrapped. Before they used to have silicone rubber tube, which is not good because it can cause obstruction, and it can cause this like there is a soot which is coming if they are burned. Okay, and then another this foil wrapped. Okay, there are special laser tube, metallic tubes, which are being used. So this is some basic points, because actually if they will ask laser surgery, they will, one of the question will be, how will you maintain the airway? Okay, how will you, because these patients can have chances of airway obstruction. Okay, and another thing, sometimes you need to have microlaryngeal tube. Why microlaryngeal tube? What is microlaryngeal tube? MLT. They are long and thin. Usually, if you have a endotracheal tube of external diameter of 5 millimeter, okay, so the length will be less. So they are longer tubes. Okay, because in number of cases, they, because of any nodule or any obstruction, like in tracheal stenosis, like in this subglottic stenosis, the normal tube is not passing, but you need longer tube. Okay, so they are using this microlaryngeal tube. Another important point with reference to laser airway management of laser surgery, nobody has mentioned. I was just thinking that some of you will be telling. What is that? Yes. You know, the people who are going for exam, what for they are waiting? I don't understand. You should be knowing these things. Until the time you will not speak out, uh, believe me, there is no advantage of studying and studying, because at the end of the day, only few things you need to speak out. So high frequency jet ventilation. There are specific jet ventilation equipment which is being used in laser surgery. It's not available in all the hospitals. I have seen actually one or two times. It occurs in our hospital. I don't have much experience about it, but usually, what is the few points about jet ventilation? What is the problem? Is it oxygenation problem or removal of CO2?
Removal of CO2, sir.
Okay, so this is the problem. And then there may be barotrauma. Okay. So whenever they are doing it, you have to be, because they will ask you to keep it minimum oxygen, maybe 25% or even air. They can also, because in Pakistan we don't have air, but in other hospitals we have air. So they can ask about this thing like that. So I
Sir,
just
if
try.
we have MLT, so why we are using high frequency jet ventilation then? Or
No, no, no. This
my
is
question
different
is,
options. Different options.
okay,
The,
which is
I'm
better?
If the people who are expert of high frequency jet ventilation, they don't use microlaryngeal tube. High frequency jet ventilation,
Okay,
there are less chances of airway, because we are using. I told you that this is a weak topic for me, but
right.
I have less experience. But it's something I have seen people are doing it. I'm not sure how it is superior or inferior than microlaryngeal tube. If you ask me,
Sure.
I would be happy with microlaryngeal tube, but I have seen
Okay,
people doing it. Okay. So, because you can
right.
say unfamiliarity, it's more important. You can say that even high frequency jet ventilation, not all of the anesthetists are familiar. Okay, so this is one of the reason. But usually, if they will be asking you this topic, I have just told you the basic information. You should be knowing the laser type, the laser wavelength, the problems, the occupational hazard you can tell. Okay, and with reference to airway, you have to identify what exactly is the lesion. Okay, and then you have to be ready for tracheostomy. You have to, always tell that these patients, the topic is laser, but you should be thinking that if the pathology for which this laser surgery is occurring is with the reference to airway, a number of time there will be chances of airway obstruction. So tracheostomy you have to tell, difficult airway, difficult intubation will be there. So you will be pre-operative assessment of airway is very important, and you will ask a number of time now in good hospitals. They are asking, they are showing you the nasal endoscopy video. You can see before how is the airway. So maybe sometime you need to have awake fiber optic intubation or things like that. Okay. So these are the concerns. So now some points about urology endoscopy. Okay. So what challenges you will face? Because actually in a number of hospital, there is a special lithotripsy unit where they are where they are doing not only this extracorporeal shock wave lithotripsy, this is one of them, but also they are using, they are doing some quick cystoscopies. Okay. And the some of URS also, ureteroscopy, urethral dilatation. Okay. So this will be again with reference to cystoscopy. The procedure may be of only 5 minutes or 10 minutes. Sometimes they are removing the DJ stunt. Okay, so these patients may be post any urology surgery or post transplant. Okay, these patients can have some malignancy again, as I told you. And usually these cystoscopy patients, they are having a number of time having this post URP, or they have enlarged prostate. Okay, so they are having, as I told you, you should be thinking about malignancy. The patient can bleed, and then it's a short procedure. There are a lot of cases which are there. They have a number of hell of comorbidities. Okay, we face challenging environment. So again, another challenge is day surgery, because they will like to do it as day surgery rather than admission. So you have to identify patients at risk, because a number of time if they are doing in local only, they are doing only with local. So very important will be local anesthesia, just lubrication, because they are using it only for lubricating. They are not interested in anesthetizing the area, the place. But if you request them and they put a lot of jelly and they give enough time for the topicalization, this will help you a lot. Okay. Otherwise, this patient can again have, like any other procedure, it can have bradycardia. Okay. It can be very uncomfortable for the patient, because there are high chances of sepsis. In this urosepsis is one of the dangerous sepsis. So they always require antibiotic before the procedure. Okay. So you should be very careful about it. High frequency jet ventilation. So anyways, do you know what is what are the things related to URS? In URS also they use laser a number of times, or they are using this urethroblast. This one, lithoblast, sorry. Lithoblast. Blast is blasting and litho is stone. So, sorry. Okay. So this is it. Out of our Bilal is here. So Bilal, can you just say a few words about your experience back in Shaukat Khanam about the radiation therapies, brachytherapy? Um, if you can speak out, if you are free to speak out, or you are busy. Okay, okay. Bilal is at work. So, anyways, I just try to give you uh, just a bird eye view of this topic. with reference to monitored anesthesia care, they can ask you question. ERCP, endoscopy, brachytherapy, radiation therapy. Actually, this is a short procedure. There is another therapy which they do is sclerotherapy. Okay, sclerotherapy is for a number of procedures. They are one actually some of the procedures they are doing it for angiomas. Okay, so angio tumors, sorry, just whenever there is angiogenic, the patient can suddenly bleed. Okay, so you have to be very careful about it. They have some oral lesions as well. There are some in the skin as well, and it's quite painful procedure. AV malformations, yes, hemangiomas. So sclerotherapy is done for that as well, and they are giving it in even in urological procedures. They are using sometimes this therapy, and the sclerotherapy. Esophageal varices also. Yes, thank you. Esophageal varices. They are using this sclerotherapy. Bladder tumors. Yes. So actually, this is a topic which they can ask you. Don't worry about it. The basic things are you have to identify the pathologies. These patients may have comorbidities. The area is out of OR, limited manpower, limited access. So you have to be very careful, and you should prepare all the necessary equipment for any, even if they are doing in local anesthesia, you have to be ready for all the emergency medications, all the airway equipment, so that you are not facing any, even if you have any anticipated difficult airway, you should have all the difficult airway equipment. Even if you are doing simple, say, because this, as I told you, that because of vagal responses, this patient can have even arrest. So we have to be very careful. A number of time there will be patients who have a lot of comorbidities. Okay, so thank you very much. That's all for today. Faiza, I hope I was able to tell you something about laser, despite my limitation for this topic of laser. All the exam candidates, I request you humbly to speak out, because if you will not speak out, you will not be able to uh, express. Because in the oral part, you don't have to you don't have to this you don't have to just tell how much you have read. You just have to be very sure what you have read. Okay, and another thing, because sometimes they are when they are doing, especially the one thing I missed. I'm sorry, I will continue for one more thing, which I have discussed before in neuro, but I will just say a few words about interventional radiology. Interventional radiology. I nobody pointed me out. Everyone is sleeping like me. I'm sleeping because I'm tired, but why you are sleeping? You should be telling. So intervention radiology, a number of procedures with reference to even from they are the patients, they are coming for PIC line. Okay, so again, these patients can have some lymphomas, leukemias, or any tumors in which they need to have this portacath or PIC lines. Okay, they need to keep it for chemotherapy or prolong antibiotics. This will be one patient group. Then another patient group like for liver biopsies. Okay, this is also a very dangerous group of patients. They can bleed. They can. Then another procedure which I have never done. It's transjugular intrahepatic orthosystemic shunt. Can someone corrects me? Tips procedure. Have I spoken out correctly? This tips.
Yes, sir.
Okay, so they can ask you. Actually, the question is seems to be very difficult, but answer is very simple. This patient will have all the problems related to liver. So you will say this will have this probably this patient will have liver CA, or the concerns related to end-stage liver disease. Patient can have coagulopathies, synthetic and metabolic problems related to liver failure, and multisystemic involvement in liver, sorry, in kidneys or heart or the hyperdynamic circulation, patient can suddenly bleed. Okay, so you have to be ready for all the disasters. Even in liver biopsy, the patient can bleed like anything. So even and this procedure like that. Then we have vascular bypasses, vascular embolizations. They are doing some procedures for varicose vein. They are doing some procedures for embolization of blocked vessels. So in angiography, you can face problems, all the problems of out of OR and like bleeding, biopsy from lung for CA, yes, angio suit cath lab, yes. So interventional angiography is actually working in cath lab is also, you can say, out of OR. Okay, so there the patients with acute coming for primary cardiac percutaneous cardiac intervention or primary cardiac intervention, they are coming. Okay, so these patients can have arrhythmias sudden. This patient can have arrest. Even when they revascularize, the patient can go in arrhythmias. Okay, so this is again an example of MAC. Even when they are doing this PCI, do you know the cardiac surgeon is still on call because there may be rupture of vessel. Okay, then perfusionist is over there because they might go to ECMO or bypass immediately. So you are only doing PCI, but everyone is on board. So you can have all the, like, it's a simple, maybe you are not doing anything. You are not doing anything, or you might need to do everything. So might be there is some arrhythmias. Okay, there may be hemodynamic instability. So you need to have vasopressors, inotropes. Okay, then another thing, they are using this thrombolytics. Okay, usually the modern thrombolytics does not have the problem of of the older, like streptokinase can have anaphylaxis. Streptokinase can cause bleeding throughout the body, especially the brain. So streptokinase was a terrible medication. Anyways, people used to survive with it as well, including my father 18 years ago, when I even don't know what streptokinase was. He received it in front of me and I have no idea what's going on. I was very happy that he's getting the treatment. But now I know what is it. Nobody use it in any developed world. I don't think so. They are using it for cardiac procedures now. So you have to be very careful. So if they are asking you, they can, by the way, they can ask you this question: how will you give anesthesia care in cardiac cath lab? So our answer is very simple. You have to be ready for any cardiac instability with reference to blood pressure, with reference to arrhythmias. Okay, so you will be following the advanced cardiac life support algorithm or tachycardia algorithm, and that's it. You have to be mentally prepared for patient getting collapse. Airway management should be ready. And so actually, the question looks very difficult, but answer is very easy, believe me. The similar is one of them. It's not available everywhere in Pakistan, but it's a bit growing trend. They can ask you is EPS, okay, electrophysiological study. This is for the identification of arrhythmias. Identification of arrhythmias. They do the, like, I have they stimulate the areas, different areas, and then they identify, and then they ablation. Okay, they identify the focus of arrhythmia and they do the ablation. Okay, retiplase, TPA, yes. So I think that's it. So thank you very much, all of you, and we will come. Any other topic, Faiza or Ikra, you want to discuss? Just let me know. Okay. So for Viva practice, because today I just changed the topic actually because Faiza requested for this laser. So I thought to just make it an out of OR anesthesia. Okay. So if anything I missed, you feel free to ask me about this topic. Tomorrow maybe we will have another session at the same time. Okay. Thank you. Thank you, Bilal, for joining and having some words of wisdom. Bye bye.